Hi everyone, welcome. This is Patricia from the International Hospital Federation. Thank you very much for joining us today, and I hope you're all safe and well. We at the IHF are hosting this COVID-19 webinar and live Q&A series to share experiences, good practices, insights, and recommendations from our members and other organizations across the globe. This series has been created for healthcare providers, including decision makers and those involved in managing COVID-19. We hope the lessons you take away from this webinar will help you in facing the crisis and beyond. I would now like to call Ihf CEO Eric Thurudin back to say a few words. Eric?
Thank you very much, Patricia. Good morning, afternoon, or evening to the participants of this webinar that is part of our series on how hospitals and healthcare service providers have responded to the COVID. It's really a great pleasure for me to be introducing today Alex Preker, who will be our moderator for this webinar that will have the format of a panel. And the panel will be discussing how the situation in developing countries was addressed facing the COVID pandemics. Let me just say a few words about Alex before he starts. He's adjunct associate professor both at Mount Sinai School of Medicine and the Mailman School of Public Health at Columbia University. Alex is also president and CEO of Health Investment and Financing. And Alex has worked many years, extensively, I should say, on health systems, including on hospitals. And he has authored an impressive number of books that are referenced for health professionals from around the world, and including the famous book on the corporatization of public hospitals, we I think all know as healthcare professionals. Alex led for many years also the advisory board of the IHF World Hospital Journal, and is a lifelong honorary member of the IHF. I really want to thank you, Alex, for taking the initiative of organizing this webinar. And with no further ado, let me let you introduce the panelists that are also welcome on board and how you will run the session. Alex, the floor is yours.
For hosting this terrific series of seminars for emerging countries and also for Western countries on the COVID crisis and its impact on hospitals and how hospitals have coped with that. I think it's really, I've been following the series, and it's an amazing series because it's the real life stuff. This is how managers on the front line, the real heroes, as our Governor Cuomo has said, these are the people that are out there fighting this epidemic on the front line and who really have learned along the way, because many of them were not like here in the US, were not primed in this kind of management. And some of the very innovative things that have come out of developing countries is really something that we need to be paying attention to as we go forward. So I'm delighted to have three panelists with me today. I have Ariel Pablos-Mendez, who's currently a professor at Columbia University, who will discuss some background about the disease and the epidemic. Ariel also had an extremely distinguished career internationally. He was head of the USAID a team for the USAID International Health Program. He was a director in WHO and also ran the program for Rockefeller Foundation before that. So he has really just an amazing career in the international sphere. Adeyi, who's the current senior advisor for health in the World Bank, former director of health in the World Bank, also has an amazing career. He's worked both in the bank with WHO, with the Global Fund, on a number of projects, and has really led, during the time I was in the bank, he led much of the public health work that we did on many of the epidemics, both infectious epidemic and also non-communicable diseases. And then we have Nandakumar, also a close colleague of mine from the time that I was working at the World Bank. Nanda now is a professor at Brandeis University, but prior to that was the chief economist of for health at USAID, and also had a number of other assignments, including a period where he worked at Harvard. He and I worked closely together when he was at Harvard, and produced a manual on national health accounts for developing countries, which is really just an amazing, amazing document, which allows developing countries to manage their finances in the health sector. Okay, I'm going to move straight into the panel. The way we're going to do things is that we're going to have a couple of rounds. I'm going to pose a question. The panelists are going to answer the question, and then we'll have a second round where we'll have a back go at that, and then we'll open up for questions for the audience. And the topics we really wanted to put on the table today and get the opinion from our experts is what are the experience that we have seen so far? What are some of the lessons we have seen so far in particularly in developing countries, but also making some reference to elsewhere, that we really think are learning experiences? And some of them could be positive learning experiences, and some of them could be negative learning experiences. So what are the experiences that we've seen? And then in the second round of questions, we'll see what are the implications for next time, how we can get better prepared for the second wave. For us here in the US, this is enormously, enormously important because as of this week, you know, as you have seen, we've had over 100,000 deaths in the US from the COVID virus. Here in New York State, this week in New York City, we still had 600 new cases. Imagine 600 new cases in the city of New York, over 60 deaths per day. That's 600 cases, new cases per day, over 60 deaths per day, and that's after 3 months of lockdown. So something really clearly has gone wrong in a very, very big way. We must listen to other countries that have experiences that may be able to inform us. And other countries are the same. I'm giving New York because I live here as an example, but it's the same thing in Europe, in other places. We must learn. Big mistakes have been made. We must do better next time around. So with no further ado, let me pass to my dear friend and colleague, Ariel Pablos-Mendez, to kick off. So Ariel, from your experience in looking at the disease, what are some of the things with this disease that make this disease different or similar? And what are some of the disease aspects? Soji will then discuss some of the aspects which deal to vulnerable populations, and Nanda will talk about the economics.
Thank you very much, Alex, and welcome all of you to this webinar. Thanks for the introduction, Alex. I must add, and in addition, I happen to be a frontline health worker. I work in New York Presbyterian Hospital, which was at the epicenter of the epidemic that we have just gone through and still going through in New York. I volunteer in the cough and fever clinic. We started a serology clinic, and we have been reorganizing the hospital, both going into this peak as well as moving now out of the peak. And again, it's been amazing to see both the leadership at the hospital level, as well as the courage and the commitment of all my colleagues, physicians and otherwise here at the hospital. So it's been an amazing experience I want to just convey to you. But indeed, my career has been in global health, and I have to say that I've been involved, of course, in responding to many global epidemics in the past. But unlike the recent epidemics of Ebola and Zika, COVID hit richer countries first and hardest so far. This has given time for many low and middle income countries to preview the nightmare COVID can unleash, which is surreal as it's evolving. And nothing really can prepare you emotionally for the actual panic that arrives once you face the actual exponential growth of the pandemic in your community. And this is what we have experienced firsthand in New York. But it also has brought, at this stage, an empirical conviction, and thus hope, that the epidemic curve can eventually abate. And of course, we will have to face questions, what happened now? And what happened in the fall? Will there be a second wave and so on? So let me give you a couple of perspectives on how we have learned globally from the epidemic can inform what we're doing here and as well as in low and middle income countries. COVID is a hyperacute epidemic. As you have heard, there's something called the R0, or the reproductive index, the number of cases one person can infect with COVID, which has been difficult to estimate, but it's been around 2.3. But unlike tuberculosis, that can also create 2 other cases over 2 or 3 years, COVID does it over 2 weeks. And so the same reproductive number leads to an explosion of cases and deaths that overwhelms hospitals, morgues, and the news. And this is what we have been seeing starting in Wuhan to Italy, to New York, and so on. Even if you were to have 3 or 4 times the annual number of flu deaths, even if that was all you got, if you compress a flu season of 9 months into a single month, you can imagine how devastating it is for the demand imposed in ICUs or so. But eventually, the curve abates after a month or 2 of this peak, and the panic that it ensues then leads to people really behaving in a way that leads to a reduction in transmission, a reduction in the R0. And what we need to stress for that is how important, and unfortunately we were not doing that enough in the United States, how important is to believe it's coming to you, because like H1N1 and other flus, it will just go through every country and community. So we must prepare with good testing. We must prepare the hospitals, the health workers, the protection equipment, and so on, but also then prepare for when this subsides and how the resources can be rotated, whether we got help here in New York from California, but now we can help those in other states, and likewise in regions in Africa and Latin America and so on. The second point I want to say, observation from this pandemic, is that COVID is an iceberg. That is, like H1N1 a decade ago, the majority of the cases don't seem to be registering in the system because we're only testing those who are the sickest, and yet maybe up to half the cases are asymptomatic, and there is a pre-symptomatic period of transmission that can add to transmission and makes it very difficult to track and to do the traditional contact tracing, which in New York we eventually, as the exponential phase arrives, we discontinued. And then the third important point on the epidemic is that there's a clear age split from the data in China, in Japan, in Korea, and then in Italy and Spain, and now here in the United States. It's become clear that 80 or 90% of the cases who result in deaths are occurring in people over the age of 65. In fact, this is a very important point in terms of the demographics of the countries so far and those in low middle income countries. But basically very few deaths, although they do occur, in young, healthy people. And in people under the age of 20, there's virtually 0 deaths in the whole world. So the deaths gets concentrated in people over 70 and below 20. You can count with the fingers of your hand in the whole world the number of children who have died. This is different from H1N1. A decade ago killed 350 cases just in the United States alone. Not the case with COVID. COVID seems to not kill children, although everybody infected, everybody can transmit, and yes, some young healthy adults can still die. Is still a minority, maybe less than 3 or 4% of the total number of deaths occur in healthy young adults. So worldwide, as Alice just pointed out, there have been over 6 million confirmed cases, nearly 400,000 deaths, and the United States, nearly 2 million cases, and we're approaching 110,000 deaths. In the last 12 hours, 1,000 deaths have occurred here in the United States. We're clearly not over. This COVID iceberg is moving to the next stage and so on and so forth. And we still have to see the end of the epidemic, even though after having hit the big urban areas first with high number of populations, the overall number seems to be slowing down. But in some communities, it's actually growing, and we must be mindful of that rotation. There is that sub-regional variability, and the timing of this makes it tricky, but at the same time an opportunity to prepare, to learn, and then to reuse resources from one to the other. COVID arrived later in low middle income countries, in part because of the global travel patterns that we know, And, but now we're seeing a surge. Latin America has become the new epicenter. If it was New York just a month ago and Italy a month before, it is now Latin America, accounting for 40% of the world's COVID deaths now. Brazil, Peru, Chile, Ecuador, Mexico are among the hardest hit countries in the world. And in terms of cases per capita, and right now Brazil is now number 2 after the United States in terms of number total deaths. And again, in Latin America, 80% of the deaths are occurring on people over 65, and a large number of the remaining are people who have comorbidity, obesity, diabetes, cardiopulmonary disease. So on the other hand, high numbers of deaths were also expected in Africa due to the fragile health systems, lack of access to preventive measures, barriers to testing, and so on and so forth. But according to WHO, Africa is the least affected region globally, with only 1.5% of the world's reported COVID cases and less than 1% of the total world deaths, which is important. There are many hypotheses that have been suggested for this apparent paradox, including the sensitivity of the virus to ambient temperature, Africa's comparatively young population. Just to give you an idea, whereas in Italy, 25% of the population are over the age of 65, in Sub-Saharan Africa or in South Asia is only 3%. So the most vulnerable to deaths are really fewer to start with, and that may account. And then familiarity with infectious disease outbreaks. We have regions who have seen many pandemics, and people have learned over time. We do learn and adjust behaviors. Despite the efforts of the Africa's new CDC, there's been low levels of testing that might also artificially lower the infection rates. But the deaths, in fact, we shouldn't be focusing too much on cases because it always depends on testing, and we have so many asymptomatic. But on deaths, that's the hard number. And still, again, Africa, demographics and others could still contribute to what has been so far a good news for Africa. But we're still not there yet. The epidemic is just arriving, and we're going to see in South Africa is taking off and so on. So I think the situation is heterogeneous in the continent, and it's just still early stage. So we have to see, and different countries are reacting in different way. And again, from the beginning, these demographics has been very important, will remain very important, and comorbidities will remain very important. This is very crucial to how we can decide to respond, as we're going to discuss in the second round of this discussion. Thank you.
Okay, Ariel, really, that's really terrific. And we'll come back to some of those points, but you've really highlighted some extremely important issues: the infectivity of this disease, the iceberg, which really is a nice image, a metaphor of what's happening here. It hits you when you don't know, you have no idea the patients are sick. Certainly in the US here, we got really hit by that. We were measuring people's temperature at the airport while thousands of people were coming in infected, and we were not detecting it. So this is really just fundamental. And then, of course, also your point about the aging, it's just so important, because this is where, particularly in Western countries, we've been hit with the nursing home. So really, these are just crucial points. I'm now going to pass the mic to Soji Adeyi, who's the senior advisor in the World Bank. And once again, Soji, you've been a dear colleague of mine throughout my career at the World Bank, and we really thank you for contributing this session. So in your case, you're going to speak to the point of how vulnerable populations and how specific groups have been affected by this.
Thank you, Alex, and want to thank colleagues at the IHF for convening this, and so thanks to everybody for joining in. I'll start with an overview and then use some country-specific illustrations of what is playing out as the pandemic unfolds. So globally, we find that the projections that the pandemic will have severe effects on poverty, and it's expected or projected to push some 60 million people into extreme poverty in 2020. And that's increasing the number of the world's population living on less than $1.90 per day to some 700 million people. And that also means that the global poverty rate is rising for the first time since 1998 during the Asian financial crisis. Now, if you dive deeper into the component parts, you find that the poor are bearing a disproportionate brunt of this pandemic in many ways. How so? When governments move to close down economies or when they move to impose restrictions out of necessity, there are some unintended side effects. And those side effects play out very differently. It is one thing to be employed full-time in formally waged jobs, and you may be able to telecommute and you keep earning your income. However, in many countries, more than 80% of workers are actually in the informal economy. This is the case in sub-Saharan Africa, for example. And so if you're living day by day and you cannot continue your job during that period, it's a very easy downward spiral into even worse poverty than you were in before then. That's one. A second aspect is the vulnerability to infection itself. Many of the poor do not even have running water in their households. It's very difficult to wash your hands frequently when you don't have water. For the poor, when schools close, their children are more likely to lose out on learning. And this also exacerbates and has the potential to exacerbate the gap that's already existing between the higher income quintiles of the society and the lower income quintiles of the society. Now, furthermore, when societies shut down, especially when those shutdowns happen abruptly, it can lead to massive dislocations of people, unplanned migrations, and untold hardship in the short run. And I think everybody has followed the news, so you're probably familiar with what happened in India, for example, when the country was shut down. Those were some of the short-term unintended consequences. In other parts, if you look at what has happened in Ghana, for example, Ghana moved fast to constitute a presidential task force that was headed by the president himself. And one of the interesting mitigating factors that they tried to address was actually food distribution, both uncooked food and cooked food in the Accra and Kumasi metropolis. That's an indication of an effort to improve the safety net. I should note, of course, that the government of India has also moved very strongly on that front. So we move from Asia, we touched a bit on an example of a country in Africa. Let's cross the Atlantic and go to South America. Things are playing out very differently in Brazil from what we have seen. The epidemic is fast growing there. And among the poor, you know that some 13 million people or so live in the favelas, the urban slums in Brazil. And they are also bearing a disproportionate brunt of this pandemic as it's playing out in that country. When people live in multi-generational, when they're crowded in multi-generational households, you cannot socially distance. It's just not practical. And people may not have running water in their houses. And it does not play out well in that situation to suggest that the younger people who are less likely to die if infected should go out and continue working, because what will they do if they get infected and they're asymptomatic? They'll come back home and infect the grandparents in the house. So when you look at all of this, the interim conclusion is inescapable. This pandemic is having disproportionate effects on the poor. Its short-term consequences on loss of human capital are likely to be disproportionately borne by the poor. And finally, I should also note that one of the ways this is playing out is through reduced incomes for migrant workers. Therefore, it will lower remittance flows back to their home countries. So for the poor in low and middle income countries, they're taking a punch locally, and they're also taking a punch in terms of potentially lost remittances. I'll pause here and look forward to the next round of our conversation. Thank you, Alex.
Okay, thank you. So you really did. That was really a terrific intervention, and I would just add and emphasize the point you made of the setback that we've seen. I joined the World Bank in 1990. Shortly after that, Jim Wolfenson came and became the president of the bank, and he changed the bank's focus from a development bank focused on infrastructure and finance to what he called a double bottom line, which was that you had to have social development in addition to economic development. And throughout my bank career, 25 years of the bank career, we worked on helping countries achieve their or get out of abject poverty, raising the extreme poverty level from $1 per day to $2 per day, and in some cases higher than that. This was a major achievement during those 20 years, is to increase. And it's hard for people in the West to understand people living on $1 a day. And that's, of course, on the average. So there's people living on less than $1 a day. Raising that from $1 a day to $2 a day or $3 a day was a major achievement. This epidemic has put things back years in terms of where the poor are. And so this has really been just a dramatic negative event for many developing countries and the poor in developing countries. Patricia, if you don't mind, just switching now to Nanda. We're now going to hear a little bit about the economic impact, which is I've given the segue from that. Nandakumar will give the intervention on that.
Good morning. My name is Nandakumar. I'm a professor at Brandeis University, and I'm a health economist by training. As we all know, pandemics kill in three ways. First is the virus itself. The second is the disruptions to the routine healthcare system. And the third is due to the economic shock and the consequences of an economic recession. What I would like to do today is really focus on the third aspect of this. For good or for bad, what all countries have done as a reaction to COVID-19 is taking aggressive steps to limit the spread of the virus and to save lives. We have done this through self-isolation, through lockdowns, social distancing, and a variety of other measures. Let us see what the economic consequences of this has been. In the United States, which was once an incredibly vibrant economy, unemployment rates are now at about 25%. That means that 1 in 4 or 1 in 5 people are without a job. 42 million people have lost their jobs in the last 3.5 months. The economy is losing between $350 and $400 billion a month. More than 60% of the small businesses have no idea whether they would ever come back. And similarly, what we are seeing is tremendous stress. This, in spite of the fact that $3 trillion, yes, I mean $3 trillion, has been poured into economic relief, and trillions more have been mobilized by the feds to ensure market liquidity. In spite of all this, economic recovery remains uncertain and very spotty. Let's take another country, another large economy, India. Between March and April of this year, unemployment rates in India went from between about 6.5 and 6.7% to around 16%. 140 million people in India lost their jobs. The Indian economy is losing anywhere around $5 billion a month during the lockdown. Close to 47% of households have seen that they're going to see a decline in income, or they already have seen a decline in income. And over half the businesses are saying that they're suffering losses and suffering income losses. Turn to Africa. The story is no different. In Africa, what we are seeing is that countries that are highly dependent on tourism and export of commodities like oil and precious metals are suffering the most. So what is clear is that a strong public health response comes with significant economic pain. And during the first round of responses, What we did was we essentially kept out the economists, the health policy people, and businesses from the discussions, and we took aggressive steps to deal with the pandemic. Yes, there have been a lot of positive consequences. We have saved a number of lives. In many countries, we have prevented the surge, or we have managed the surge, some better than the others. But at what cost? What cost? What we are increasingly finding is that one size does not fit all. Countries that have very limited fiscal space and that have very high debt to GDP ratios, and those that have a large informal sector are going to find it much more difficult to deal with the pandemic than others. We should never forget the fact that pandemics impact the poor, the marginalized, the migrant worker, and the most vulnerable in society far more than they do the rich or the upper middle class. How many of the poor, actually, who are being driven into poverty will also suffer poor health outcomes because there's a strong link between poverty and health? And how many of these people will actually die from this? We actually don't know. What we do know is economic stress is causing an increase in suicides, will increase mental health problems, alcoholism, substance abuse, and domestic violence. So we are paying a huge price for our actions that we really did not factor in when we made these decisions. Or maybe we factored them in, but more implicitly than explicitly. What I would like to submit, and what I do hope, is that we learn from the first round. We recognize that the situation in low and middle income countries is really going to be very different from what we are observing in some of the other countries. Some countries like Vietnam and Hong Kong have done exceptionally well. We cannot, going forward, have this dichotomous choice of first trying to save lives and then figuring out how we are going to save jobs and save the economy. For most countries and most of us, this is not a choice we have. We have to find a way to save lives and save jobs at the same time. These are not easy decisions. These are going to be hard decisions, but hard decisions have to be taken. And while doing that, we need the public health people. We need entrepreneurs. We need the business sector. We need the economists, and we need the political leadership to come together and carefully look at the trade-offs and then make the decisions. Each country should craft its own way forward based on its own realities. This idea that everyone will do the same thing is not going to work. We also need to recognize that in an increasingly global economy, actions taken by high-income and developed countries can have extremely adverse impacts on low-income countries and low-middle-income countries. So the pandemic has kind of given us some hard lessons, but I hope we take these lessons and incorporate them into our policies going forward. Thank you.
Well, thank you, Nanda. And I think it's a beautiful segue into what we want to talk about now, because we want to put the doom and gloom behind us. It has been a tough 3-4 months for everybody. We now want to look forward with some optimism and see what is it that we can do as we go forward in a positive way that will manage the crisis in a different way if there's a second wave. It may be a second wave of this virus, or there may not be a second wave of this virus. But if there's not a second wave of this virus, there will be another virus, or there will be another pandemic. So whatever we're learning now may be applicable to the second wave of the COVID, or it may be applicable to next time we are confronted by a major threat like this. Let's just have a quick round from the panel again before we turn to the audience who are signing in. If Ariel and Soji, if you can just say a couple of things of what would be your takeaway messages from where we've gotten to today as what one would want to maybe do differently going forward. Ariel.
Well, thank you very much. Of course, every pandemic is different and every location is different. We just heard from Nanda. And at the same time, there are some principles that we can learn and adjust. And I think that We have to learn from what is going on. And Nanda already made a point that in order to save lives, people had economies going to lockdown, and that the price of that may be too high for a generalized lockdown. I will insist that knowing that 95+ percent of the deaths occur in the elderly, that we must do everything to protect the elderly. Difficult as it must be, it is not as difficult as facing lockdowns. In the United States, 43% of all deaths occur in nursing homes. In In Minnesota, 81% of all the deaths in nursing homes. So it should not be too difficult to protect those nursing homes. And so certainly we have to do certain things in other places where nursing homes are still not as prevailing, where intergenerational households are more difficult. I appreciate the difficulties of that. But clearly those are the people who die, whereas the young and healthy rarely do. They do, but rarely do. And I know it's difficult to risk anybody. And in a way, the response has been, for that reason, generalized lockdowns, but they're not sustainable. And in the end, then we have to worry about reopening. And it is the same thing. As you try to reopen, you're going to the same issues of going back to square one. So what can we say? I've also been very much a proponent, and that's my personal view. We have discussed a lot in this group about these issues of the importance that epidemics end for 3 reasons. 1, decimation of the susceptibles. So those who are most vulnerable, the elderly, the sick, and those with aggressive behaviors, they are the ones who die away first. 2nd, growing immunity. And that is a fact that has helped end most of the other viral pandemics like H1N1 a decade ago. And 3rd, behavioral adjustments. And clearly behavioral adjustments work. If you stay home, if you wear a mask, that cuts transmission, and it works. And it's very important to flatten the curve, as we have heard, so that we don't overwhelm hospitals and so on. But it really squishes out, prolongs the pandemic. And as I said, the lockdowns cannot be sustained. For that reason, I've been very much in favor of the model that Sweden has taken, where they have indeed doing exactly this, a policy of age bifurcation. The elderly and the sick stay home, and the young and the healthy go back to school and to work. They never close schools, they never close restaurants. They encourage them indeed. And while indeed Sweden has had a higher level of mortality than the neighbors Nordic countries, their actual pandemic curve is not different than that of the UK, Spain, Italy, the United States, but without closing the economy, indeed showing mild economic, little, but still economic growth, where we have seen not economies shrunk by 20, 30% and so on. So I think clearly people need to at least study well the experience of Sweden. And when we look back at this pandemic, we will have to accrue the deaths that would result from lockdowns, from the poverty, from the distractions of the health systems, and so on. So I think I would say to you is that in the end, stay tuned to that. If you want to have data, the data will be serological testing. Is different than the PCR test of the active cases. Is suggest antibodies, and so far, many questions as to whether serology is accurate. Certainly we don't want inaccurate tests. 2nd, whether there is enough of that immunity accruing, and indeed early on there will be little, but it grows exponentially. So that in New York, it was already over 20%, New York City over 20%, even before we had the peak. So by now it could be 30, 40%, but it may need to be higher. In combination with social distancing and masks, it may be less or sufficient to slow the epidemic. What I expect them to see is not a second wave. People have been scared of the second wave because of the 1918 Spanish flu pandemic, but data there was even poorer than today. And we have only speculation as to what the actual waves. People actually say that in 1918-19, there were 3 or 4 waves. And the first big wave was muted because the military did not want to reveal the data. And also there was a clear increase after everybody went at the end of the war back everywhere around the world, from Australia to the United States. So the 1918 second wave concern, in my view, has been exaggerated. And in this case, at least in New York, the countries that have gone through large peak can expect to have more of the hammer and dance model. When you have a big hit, as we have seen in New York, Italy, Spain, after which we're going to have a dance of reopening, distancing, learning, some increases going down, but there will be wavelets as we ratchet up the immunity in the population, so-called herd immunity. and the epidemic starts slowing down. We will not reach a vaccine in time for this epidemic to undergo this natural course, and this is my view. And the vaccines take time not because of the biologicals, but because of the need to ensure they are safe, and that requires time for evaluation before you give it to billions of healthy people. And so be prepared for a year, at least in New York. We're going to be prepared for these wavelets and really periods of uncertainty of 3 to 6 months, and then eventually conviction that this is going to be behind us. But places who actually did a good job and flattened the curve early on, like South Korea or Taiwan or Vietnam or Thailand, who had done a very good job. My concern is that they remain vulnerable, and the virus will continue to find ways to reach the population. And so it will be sluggish, but probably it's better than the peaks that we have had here. And I just want to say that during the peak is a nightmare. Hospitals have to reorganize for that. Fantastic leadership. But eventually the peak subsides. When the peak subsides, then you have to reorganize back to a new world. It's no longer normal. It's a new world where hospitals, especially private hospitals, will have, as ours, will have half their hospitals will be empty. Their procedures that generate their income will not be happening. And there will be a period of economic distress for the hospitals after the period of the actual epidemic peak, for which we all have to prepare as well. But in the end, it's the points that Nanda emphasized, is the most vulnerable and the poor that we need to try to do everything to protect both from the virus and from the economic impact. Thank you, Alex.
And you have emphasized one thing, the basic principle of public health, hygiene, wash your hands, don't spread the thing, wear a mask if that's the thing that spreads. These are just basic public health issues that should not be politicized, should not be put in the political realm. These are just public health, good hygiene standards that we must take forward in the future. Soji, on the poor, what are some positive messages for the poor of what we can do there? And we need to switch to the discussion. So if you don't mind just making this really quick, and then if there's specific things, we can bring it out in the discussion.
Alex, thanks. I'll make this a fairly sweeping rendition because that will be the most efficient way of using the modest time available so we can go on to the conversation. Based on what we are learning, I would say as we move forward and anticipate potential spikes or also look forward to other potential pandemics down the road, let's keep in mind that we're looking at an interplay among three things. The first one is a series of policy levers that we've already talked about and also reflected in the background paper. The second one is the fact that trade-offs have to be made. And the third one, which we need to be explicit about so that it's in the lines and not between the lines, is the importance of leadership, country leadership. It's very important. And I think it's fair to say that in the course of this pandemic, we have seen variations of executive competence and executive ineptitude. And there is no correlation between executive competence and income per capita. So as we go forward, one of the things to learn is the importance of clarity of leadership and the importance of science-based decision-making in matters such as this. The second one is the importance of moving fast and ensuring that in formulating and executing the public health response and in formulating and executing the social protection response, the impact mitigation response, that there is a lot of emphasis on equity such that the poor are the most looked after in this situation. The third one is the importance of strengthening and developing institutions that will be at the forefront of outbreak detection and response. And in this situation, I think we are seeing the importance of institutions that work at the country level and also at the sub-regional level. So I want to cite a specific example and give credit to the Africa Centers for Disease Control, because on the poorest continent in the world, it is the Africa Centers for Disease Control, Africa CDC, that has spearheaded inter-country coordination, that is spearheading the brokerage and provision of technical support to the countries, and is also now spearheading pooled procurement on the continent and for the continent of diagnostics, for example. And they have now launched something called the Partnership to Accelerate COVID-19 Testing in Africa. There's a lot of unpacking to do there, but I think that needs to be said. Now, one of the final things that we're learning, which is also very relevant to the to what we might do in the future, is that the pandemic led to a dramatic market failure in terms of the imbalance between the demand for critical equipment, PPEs, and diagnostics on the one hand, and the supply on the other hand, for a whole range of reasons. Whether it's because production shut down, or in fact, production did not shut down, but because there were export restrictions or other constraints in the global north or in China, where most of the equipment were being manufactured. And which means that the lower and middle income countries, where a large number of the poor reside, did not and do not have access to adequate supplies. What is this telling us? I think there's an emerging consensus that matters of pandemics are national security issues. Therefore, when we look at the market failures and we consider the national security issues, there's a case to be made that those countries and subregions might actually wish to consider alternatives to ensure that this never again happens. Will there be continued reliance alone on the current model? What kind of economic incentives would be necessary and useful to expand production capacity? And finally, what are the measures that will make sense to create more robust supply chains, shorten the supply chains, make them more resilient and more responsive, as my colleague Prashantya Dev will say, and also create redundancies in stockpiles? Because all of those are macro measures and meso measures that will end up protecting the poor, and they need to be addressed head on. So I will pause here, and I'm looking forward to a very spirited discussion. Thank you.
Okay, well, thank you very much to both of you. We'll now turn to some feedback from the people who dialed in. Patricia, I think you were going to forward to me a few of the questions so that we can put some questions to the panel. And maybe while you're doing that, if we have Christine Valencia online, maybe Christina could just say one or two words about what's happening with Vietnam. Christina has been working in Vietnam for the last 4 months on contact tracing and other things in collaboration with WHO and CDC. And Vietnam has been put forward without a question as one of the case stories of really a major success. If I was going to ask you, can you say one or two things that you think, without going into details because we don't have the time, can you say one or two things of what it is that Vietnam did right that you think maybe other countries could do next time around?
Hi, thank you, Alex. As you rightfully said, I spent the last 4 months working with the WHO down in Vietnam as part of their contact tracing teams. And I think the two biggest lessons that we learned from the effective work that we did was, one, really the aggressive and cohesion amongst all the teams, and really aggressive of contacts, the tightened border control and isolation and hospitalization, early hospitalization of cases. So Vietnam went on complete lockdown, no foreigners were allowed to come in, and any of those that came in, either foreigners or nationals, were immediately sent to isolation facilities for monitoring. So if I can say those two are most likely the main takeaway messages that we had seen in the last couple of months.
Christina, unfortunately, it went blank. We heard the second one with the border control. What was the first point?
The first one is the aggressive and cohesive contact tracing that we had throughout the country.
Right. Okay.
Which was mainly testing of not just cases, but also contacts. So testing of contacts is critical due to the fact of this sporadic pre-symptomatic transmission that we saw that was mentioned earlier by Dr. Mendez, which has now been asked to be included in the case definitions at national level in Vietnam, which is something very important to keep in mind.
So really, really terrific, because I think this is one of the things that we've been observing as well. You know, aggressive contact tracing initially, you got to get on top of it. If you can get on top of it immediately, like Vietnam did, like maybe Hong Kong did, you know, these are countries that are right next door to China. And it's extraordinary when you think of Vietnam having the same population as New York State, and Hong Kong having the same population as New York City. And when you think of the fact that New York City has had thousands of deaths, New York State has had thousands of deaths, and Hong Kong and Vietnam have had less than a dozen. So, I mean, this is just, it's extraordinary. And I think we must learn from that. Patricia,
Alex, I think
yes.
One last thing to add, the understanding of countries of what contact tracing really means. Contact tracing is not self-reporting your symptoms. Contact tracing, or aggressive contact tracing, is really monitoring, following, and testing all of those that have been in the proximity of a case.
Right. Thank you. Patricia, you were going to read out to me, I think, some of the Q&As.
So Alex, I will take that.
Okay, if you don't mind. Thank you, Eric.
Yeah, so because we have many questions and I'll try to cluster them into one or two. So there is a number of questions around still the dynamic of the epidemics. We heard very well what Ariel has shared with us, but when we look at the current situation, we are seeing, even though there has been aggressive contact tracing in Iran, that a second wave is happening there. We have seen that a situation like in Sweden, where there hasn't been such a severe lockdown, the circulation of the virus is still very high and the politicians are very much under fire. And that aged society like Germany or Japan, which are the most aged societies in the world, have been among the ones that has the less death per population. So somehow, even though the dynamic of the epidemics is described around this risk factor, the reality that we are facing today is still raising a lot of questions on how policymakers should move ahead, because definitely nobody can afford to go through a hard lockdown for a long period of time, as it was very well described in the presentation by Mana.
Yes, Soji or Ariel, does one of you want to, let's just have one response and then we'll go on to another question, because we're running out of time and we want to at least have one second question. Just a very short response on that.
I think to Christina's point, to emphasize that contact tracing can be very important in the very early stages of an epidemic. Once it reaches a exponential growth, contact tracing is just becomes not only very inefficient, but also ineffective. And so is do it early, do it well. And lockdowns, I just want to make a point. The lockdowns can actually not only destroy the economy, but also lead to police repression. We've seen people being beaten only because they don't have masks or going to jail. And again, back to Sweden, I want to emphasize, I really want you to look at the trends in Sweden. The trends in Sweden peaked 2 months ago, and they've been going down, up and down, because there's a weekend reporting lag. But then, as you can see, the trends in Sweden continue to decline for the last 2 months. And I think it's very important that we look at Sweden, because their model is the only sustainable approach that we have seen. Now, of course, with those exceptions that early on can stop, the concern will be what happened in the next 6 to 12 months. And I want to overemphasize the point that was done by Olusoji, that leadership is paramount. And clearly, my colleagues in USAID, who played out many scenarios in response to pandemics for the United States and for the world, in all of the scenarios, and they play every possible angle, source, geography, virus, et cetera, the one variable the models never considered was failed leadership. So the sadness that having so many populist governments around the world and that dismiss data, that dismiss science, and that police instead of become understanding is cannot be emphasized. So unfortunately, that's something, as so you said, that is not related to one level of economics, but it happens to be a period of history when that's been an issue. So leadership very important. Look at Sweden, check serology, and do early on, if you can, contact tracing. But let me say also, the contact tracing is what we did in the 19th century. Vaccine is what we did in the 20th century, and they never arrive in time for this type of pandemics. We need to look in the future for new ways. We know there may be millions of viruses waiting to jump from mammals to humans. There is a project called the Global Virome Project that will try to identify them before they jump on us. So we need to think new ways to address the pandemic risk in the future as well. Thank you.
Thank you, Ariel. And so you want to just make a closing remark, but also maybe addressing the issue about, there are exceptions where maybe older population have not been. We hear so much about Italy where older populations have been decimated in the US, but there are examples which have very old populations like Japan and other places, which actually that didn't happen. So maybe in your closing remarks, something on the on those.
Thanks, thanks, Alex. I think it boils down to two words, in my view. One is learning, and the other one is humility. This pandemic is still unfolding, and there are many things that we still do not understand. In fact, at the moment, we're basically focusing on understanding the what. And I think we need to pay a lot more attention to understanding the why, the how, and the why. So what accounts for the variations within countries and the variations across countries, even after adjusting for age profiles in the population? What in hindsight were some of the benefits of moving very, very early and aggressively, and what were some of the drawbacks of the way those things were implemented? For example, the comparisons among Japan and Sweden and Italy, for example. We need to unpack those. We need to learn them. My sense of the Swedish case is, again, with a caveat that we're still learning and we need to be very humble about it. My sense of it is that they went into it with all good intentions, but it also does come across as if there was quite a bit of being excessively self-assured and therefore hubristic about it. And the more recent evidence from Sweden is actually indicating that they are now rethinking that approach. Let's see how it works out. I think it's still too early to draw very firm conclusions on this. If you don't mind, Alex, there was an online text question from Patrick Lukolai. Hi, Patrick, on lessons that we learned from a prior exercise in public-private partnerships, the Affordable Medicine Facility for Malaria. So I'll cut to the chase, Patrick. I think in hindsight, the lesson that is very glaring is that the decision makers should have stuck with the science and the evidence, which showed that phase one of it worked, but they did not stick to the science. And that's why it did not continue the way it was supposed to have continued. So again, we are learning the importance of sticking with the science and sticking with the evidence. The second one is to pay greater attention to local and international efforts to support local manufacturers so they can achieve the quality standard for pre-qualification, so they can achieve economies of scale. Now, final comments on the immediate question at hand. I think it boils down to the level of institutional competence and institutional preparedness at the country and sub-regional levels. If we have institutions that work well at the country level and institutions that work well at the regional level, I think a lot of the issues that we are confronting and struggling with will probably be mitigated. And so for the future, it's important that countries and development institutions that work with them really invest in local institutions. When something like this hits, and you find that Western Europe and North America become very, very inward looking and preoccupied because they have their own problems to deal with. This is just their reality. You'll find that it becomes every country for himself and every sub-region for itself. So advanced preparation, make sure your own institutions work, and yes, leadership competence is crucial. Thank you.
Well, thank you very much to the panel. Just as a closing remark, there was in the question, there was also the question of impact on gender and what are some of the basic public health things that can be done. Let me again, in my closing remark, just say that I think one of the key things that we have learned from this epidemic that we need to take forward is that good public health measures must not be weaponized from a political point of view. It's something that should remain in the domain of people who know what they're talking about. It should not be stereotyped as wearing a mask being an attack on your masculinity. And it should not be stereotyped as taking a public health stance as opposed to other stance becomes reflective of certain political views and whatever. And we're seeing this not just here in the United States, we're seeing this in many places. It is on the gender side, of course, women are the caregivers. They're the ones who are often taking care of people in nursing homes and at home when you have older people. The gender issue is a very, very big issue, and then there needs to be more attention to that. So in closing, I just want to thank the Federation for hosting this series of seminars. They are really terrific. Thank you, Eric and Patricia and the team for making this possible, and for the panelists for taking your time. I know, Ariel, you're a frontline worker, you're taking time away from patients. So do you have responsibilities globally. Really, this is, we really appreciate your coming in on this.
Thank you.
Thank you, Alex.
Thank you, everyone, and have a nice day, evening, or night.
Yes, thank you very much, Eric, Alex, Soji, and Ariel. To all our participants, just a reminder that the video recording of this webinar will be available on our website, and we will notify you via email when it's available. Also, we still have a few webinars signed up in the next few weeks. We hope you'll be able to participate. If you would like to register to any of them, please just go to www.ihf-fih.org/webinars. So we hope to see you there. In the meantime, please stay safe and healthy. Together we'll overcome this crisis. Thank you very much again for joining us today. Alex, Soji, and Ariel, thank you so much for this wonderful discussion and your contribution.